Good morning, everyone. It is 8:30, and we are going to call the Senate Public Health and Welfare Committee to order. Before we get started on bill hearings, just kind of give you guys an update of scheduling from here on out. Tomorrow, we are having our confirmation hearing for Acting Secretary Stanek Committee. For those of you that have not been in hearings before, just to give you an overview of how we're going to handle the meeting tomorrow. Since I know a lot of people have questions, we're going to start to my left with Senator Thompson and work our way around, and we're going to end with Senator Stephan. Each senator will have 5 minutes to ask the secretary questions and allow her time to answer, and then we'll just move on until we are finished. Hopefully, timing permitting, then we will take action on the confirmation from this committee. We will have 3 options at the end of the confirmation. 1, recommend that the Senate pass or confirm the appointment. 2 is not to recommend the Senate confirm, and 3 is to offer no recommendation. I guess there is a 4th, we could not take action and it dies, but then after so many days, it would automatically go to the floor. So there are actually 4 options, but we'll plan on taking one of the 3. So whatever the committee's will is at that time. This is the first day back from turnaround. Everybody that is listening online, it is a short period. We do only have 3 weeks to get all of our work done, and then we are on the floor all day, starting on the 21st, so the 18th will be our last day to have any hearings or work any bills. So it doesn't look like we have a whole lot of bills currently coming over from the House, so I don't anticipate us rushing a whole lot, but there's always that opportunity when we get to the last few days that everything gets kind of hectic. So with that, anything that we have a hearing on or had a hearing on that is an exempt bill, if you do have amendments, and if you want to look forward on some of the bills that are on our calendar for this week, please let Jenna know so we can get those. She can have plenty of time to get those amendments worked so we can work the bills. Our agenda for next week, what we are going to hear next week, Tuesday, March 8th, we're going to have a hearing on Senate Bill 489. And then on March 9th, we're going to have a hearing on Senate Bill 274 and Senate Bill 275. I'll give you the short titles. 489 is removing certain regulatory authority concerning infectious or contagious diseases from the Secretary of Health and Environment. Senate Bill 274 is amending statutes relating to the powers, duty, let me read the right line here. Amending the scope of practice disciplined by the board and license renewal procedures for naturopathic doctors. 275 is allowing naturopathic doctors to engage in the corporate practice of medicine. And then also on Wednesday, when we're having that hearing, we're also going to hear from the reviser and research on what the difference is between 274, 275, and 539, Senate Bill 539. Senate Bill 539 is a bill that has not made it to this committee, but is anticipated to. And then on Thursday, tentatively, if it gets referred to our committee, we're going to have a hearing on Senate Bill 501, requiring employment and training to receive food assistance and requiring cross-checks and verification to receive public assistance. So that's our agenda next week. With that, we are going to go ahead and open up the hearing on Senate Bill 460, and with the revisor's office to give us a bill explanation, Jenna Moyer.
Good morning. Thank you, Mr. Chair, members of the committee. Senate Bill 460 is a bill that was drafted upon recommendation of the Child Welfare Oversight Committee from this spring, and it is a mirror of a bill in the House, House Bill 2632. That bill passed out of the Children and Seniors Committee, and it's currently below the line in the House and was blessed on Wednesday. And this bill would amend sync statutes as well as create a new statute in the Child in Need of Care codes to create a program within KDHE for child abuse review and evaluation, which the bill uses the acronym CARE. And this CARE would provide recommendations to DCF upon referrals. And I'll be doing this bill a little bit out of order based upon how things progress during a child in need of care investigation, not necessarily the order in the bill. And I hope that it will make sense to you. So when this bill amends in Section 3, KSA 382226, and that involves investigations for child abuse and neglect. And the new part is in subsection I, and it would say that when the DCF secretary has an investigation of physical abuse or physical neglect conducted pursuant to this section, so when there's an investigation into child abuse or neglect that concerns a child 5 years of age or younger, the DCF secretary, law enforcement agency, or a law enforcement agency designee shall, meaning required, are required to make this CARE referral for such child. And in any other investigation of child abuse and neglect, DCF or the law enforcement agency or their designee may make a CARE referral. And a CARE referral is defined in KSA 382202, and it would be a new subsection I. It's a child abuse review and evaluation referral, or CARE referral, is a brief written review of allegations of physical abuse, emotional abuse, medical neglect, or physical neglect submitted to or submitted by the secretary or law enforcement to what's going to be created in this bill, a CARE, or C-A-R-E, resource center for recommendation that this child would receive medical care that may include a CARE examination. And that's another thing defined by this bill. A CARE exam would be a forensic medical evaluation of a child alleged to be a victim of child abuse or neglect as required by Section 3 of this bill and amendments conducted by a care provider. And this bill would create within KDHE a program to train these doctors and to oversee the individuals who are part of this network to just collaborate and improve services to children alleged to be a victim of abuse or neglect, which is what happens in Section 1, that these providers, after the referral is made, would be required to conduct the examination and submit a report and provide that information to these the CARE resource centers. And then this would also create a fund just to pay for all of this, and then it would allow the Secretary of KDHE to adopt rules and regulations to implement and administer this act, and it would be a part of the sync statutes. And I'll be happy to answer any questions.
Senator Petty?
Thank you, Mr. Chairman. When you said create a fund, would this be a fund that's created by DCF? I mean, by Department of Health and Environment? Create.
It would be under the Secretary of KDHE. So this program would all be created in KDHE, but it's supposed to collaborate with the Secretary of DCF on those referrals.
So KDHE would create the fund?
The fund is created within KDHE. Yes, they would have the oversight and yeah, they would be the ones making the expenditures, would be KDHE.
Thank you.
Committee, any further questions for Jenna? Okay, seeing none. Jenna, thank you very much. In committee, before we get into proponent testimony, I just wanted to give you a little bit of what went on during I think it was the Child Welfare Committee, Joint Committee. This was brought up, and there was a lot of discussion on this and how it was to get implemented. So the committee felt that it was important to at least get it started and have a hearing and work out any issues that might arise. So if you guys see anything or please pay attention to whatever the proponents are saying. If there's some things that we need to tweak, we're not sure, but we think we did a pretty good job during the interim. But interim committees do get kind of hectic at times. So with that, we're going to go into our proponent testimony. And our first proponent is Senator Baumgartner.
Thank you very much, Mr. Chair and fellow committee members. It is a privilege to speak today about Senate Bill 460 because it was something that considerable time and consideration was given during the interim when we met in the fall. I believe that the CARE exams are a very necessary step beyond that visual contact that we've already put into statute by law enforcement or agency workers. I think that Jenna did a wonderful job of explaining this bill, but I do want to highlight a few things. Again, CARE is that child abuse review and evaluation. And it's not just a perfunctory, we're going to review what's been submitted and we're going to evaluate, but it really is going to go a step further. And I'm going to just give you an example of some of the testimony that we heard during the interim. Of course, there was conversation, and I've spoken often about it, about a little 3-year-old named Olivia Jansen. Olivia Jansen lived in KCK, and her grandparents, Elizabeth and Howard Jansen III, they repeatedly contacted law enforcement as well as DCF saying, we believe that Olivia's life is in jeopardy. We believe that she is being abused by her biological father and her father's girlfriend. Now, her biological mother was already in prison. So the concern was what was happening to Olivia at the hands of her father as well as her father's girlfriend. They contacted DCF, they contacted law enforcement. At the time that their concerns were expressed, we were in the beginning throes of COVID, so that DCF contact was done not in person, but was done virtually. Law enforcement stopped by, but there was no exam. There was no CARE exam. Interestingly enough, about a couple months after these concerns were initially raised, Elizabeth's father contacted law enforcement to say that little 3-year-old, I said Elizabeth, it's 3-year-old Olivia, was missing. In fact, law enforcement found her body in a shallow grave not that far from the family's home. The girlfriend did testify in her hearing, and she pled guilty, and she has now been sentenced to 31 years in prison. Her father has finally accepted and admitted he is guilty, and he is yet to have his sentencing meted out by the courts. What's important about Senate Bill 460 is it officially codifies that training process for a forensic evaluation for children that may be victims of abuse. Now, what's interesting is they may be victims of abuse, and this is why it's so important that it be a forensics evaluation. During the interim, we learned from a variety of different parents, law enforcement, as well as members of DCF, that determining the difference between an atypical development of a child or actual physical abuse is difficult to determine unless you've had that forensics training. I'll give you an example. A father testified how their young child was away from the family for more than a year because he did have an accident on the farm. He fell, but the ER doctors were not familiar with the particular condition that this little boy had, where his head physically was growing faster, abnormally, atypically faster than it should have. They contended, the healthcare providers contended that this was all due to abuse. And it took months and months, nearly a year, before an actual diagnosis was made where it was simply an atypical issue for that child. So all that time, he was not with his parents. He was in the custody of foster care. There's a difference between a childhood injury versus an injury due to abuse. And there's also a difference between an abnormal physiology compared to neglect or abuse. So sometimes there are internal problems that a child has, and unless there is this actual forensics evaluation, it's really difficult for a physician to determine, is this just the physiology the child was born with that isn't normal, or is this due to being punched repeatedly in the stomach and or thrown down the stairs and things like that? What I really like best about Senate Bill 460 is it's taking a pilot program that DCF sponsored, and it's taking pediatricians that have had this forensics training, and so they are the ones that are going ahead and doing this care exam. And this is not to discredit ER doctors. It's not to discredit the pediatricians or family practice physicians that we have in our state. We're simply saying they don't have the forensics training that is really important, that's paramount for a care exam. It also, and let me just say, you're going to hear testimony from 2 physicians that have that experience. They've been reaching out to pediatricians and family practice physicians throughout the state. Those other doctors are very much wanting to have this training. They're willing to participate because they feel that when we are looking at what's best for vulnerable children, what's best for families, it's to make sure that they have the physical exam that's necessary. And that gets us to what's a part of that training for forensics evaluation. It includes medical-based screenings and forensics evidence collection. You have to be taught what to look for. You have to be taught what information to collect. And the third component that I particularly like about this piece of legislation is that it sets up a means for funding. It's the funding for the review and the evaluation for those exams and for the training of our care providers. We want folks that have received that additional training. They should be compensated because they are saying, I'm willing to be trained to go above and beyond for my community. And when we look at the state of Kansas, we know, in population, it might be relatively small with just about 3 million, but if you walk it, or if you go to other parts of the state, you want to make sure that we have folks in all areas of our state that are able to help law enforcement, help our agencies that are trying to support the well-being of our children, and this bill does exactly that. So, Mr. Chair, thank you for this opportunity, and I'll stand for questions when we've heard from everybody else.
Thank you, Senator. In committee, we will hold questions until all proponents have had an opportunity to speak. Our next proponent is Mel Huddleston, Executive Director for the Kansas chapter of American Academy of Pediatrics. Welcome to the committee.
Thank you. Thank you, Chairman Hildebrand and members of the committee. Senator Baumgartner did a great job, so I don't know that I have a whole lot to add. I do represent the Kansas chapter of the American Academy of Pediatrics. We have about 450 members that live and care for children in communities all across the state in both rural and urban areas. Our testimony was submitted in partnership with the Kansas Academy of Family Physicians, and both of our organizations feel very strongly that this Senate Bill 460 will provide an important framework and workforce to really support children and help protect them from dangerous situations. And so this bill does provide a system of support for our physicians throughout the state. It gives them access to training and mentorship from these child abuse pediatricians that they simply don't have right now. So it really will boost up what they're able to do across the state. The bill does require about $819,000, of state general funds into KDHE's budget in order to both establish the reimbursement system as well as training for these physicians across the state. We have met with the chairs of the appropriate budget committees and are pursuing inclusion of the $819,000 in KDHE's budget. Funding will not be added unless the bill passes. Therefore, if the policy passes, we expect resolution of the funding piece during omnibus. So thank you for your consideration of this important bill. This is a way that we can all work together to protect Kansas kids. So I will stand for questions at the appropriate time.
Thank you for your testimony. Committee, our next proponent is Dr. Jennifer Hansen. Welcome to the committee.
Thank you, Mr. Chair and members of the committee. All right, I'll get a little closer. I am a child abuse pediatrician in the Kansas City area, and I am going to speak for both myself and Dr. Killo, who couldn't be here today, as well as Dr. Carrie Weeks, who's a child abuse pediatrician in the Wichita area.
Doctor, could I back up? Could you go ahead and repeat your name?
Sure, Jennifer Hansen.
Thank you.
I wanted to, I guess, give you some insight into how this works in practice. In the Kansas City area, obviously, we serve children and families on both sides of the state line. Missouri has a similar program to this that has been in place for several years. There are several other states in the country that have similar programs as well. And so we have experience both working within that system. And then I believe Senator Baumgardner mentioned there's a pilot program of this program that, as described in the legislation, that's in effect in both Johnson and Wyandotte counties currently, that myself and Dr. Killo have been partnered with DCF to sort of roll out. So in practice, we're not changing the way that DCF investigates child abuse evaluations. We're simply adding another layer of information to what they're doing already. And so what that involves is when they get a referral for child abuse on young children, they complete a one-page form that really should take them a matter of minutes to fill out, and it gets emailed to a central email address that myself or one of my colleagues would review. It contains sort of some basic information about what is the age of the child, what is the allegation, and does the child have any known injuries. And using that information, we who are board certified in child abuse pediatrics and have fellowship training to do these evaluations, then provide the DCF workers with a recommendation for whether or not this child would benefit from a medical evaluation and what type of evaluation would be best. So we may say that based on these allegations and the information that you have, we don't actually think this child needs a medical exam. They still may need DCF intervention, but medical may not be what this family needs. Or we may say, hey, these things might be concerning, but I think this is something that their regular family doctor can take care of, so they should see their regular doctor. Or we may say that based on these concerns, we think this child does need a more specialized medical exam with a care provider. And so the bill sort of sets up these two systems in parallel, one being that referral system where we can provide that information at the beginning of an investigation. And secondly, it provides the framework for setting up the care network. So what this would be is family medicine doctors, pediatricians, emergency room doctors, nurse practitioners, physician's assistants across the state of Kansas who would be interested in having this additional training so that they can do these care evaluations. They would come to an initial 2-day training that would be put on in conjunction with KDHE, but with the expertise of child abuse pediatricians doing that training for our local medical providers so that they know what kind of things to recognize and what sort of additional evaluation, x-rays, lab work, testing needs to be done for these kids. In addition to that initial training, there would be some requirements for ongoing medical training, continuing medical education. As well, our medical providers across the state would be directly partnered with one of the child abuse pediatricians in the state as a mentor, so that on a random Tuesday, when they have one of these cases in their office, they have a direct contact for someone they can call and say, I just want to walk through this, make sure I'm not missing something, or does this sound right? Just to give them that extra layer of support for when they do these evaluations, so that the kids who are in Western Kansas who are not conveniently located near Wichita or Kansas City can still get the same level of care that they would if they were in Wichita or KCK. The pilot program in Johnson and Wyandotte counties started in October of this year, and myself and Dr. Killo have been completing those reviews that are emailed to us and returned. I just wanted to share a couple of examples because, like Senator Baumgardner mentioned, we want to make sure we're not missing abuse, but we also want to make sure that we're not calling something abuse when it's not. And so in the past, where are we? We're in March, 4 to 5 months since we rolled out this program in October, we've had examples of both of those scenarios come through this pilot program in Wyandotte and Johnson County. So one example is a very young baby, about a month old, who presented to a local doctor's office and had patterned bruising on her legs. The provider recognized that it was bruising, but did not recognize the significance of it. And so somebody else, not the provider, made a hotline report. This was then referred to us, and we were able to get the baby in to see us. And she did have bruising that was patterned from being squeezed and grabbed abusively. She was able to have the rest of the workup that included x-rays, and she had a fracture that we found that we wouldn't have, a broken bone that we wouldn't have known about otherwise. And so we were able then to get the right medical evaluation and the right information to DCF so that they could make the right moves for making sure that this baby stayed safe. On the other side, there was a report made by a daycare for a child who had just started at a daycare. He was about a year old, and they made a report for bruising on his body. And the mom told the daycare, nope, that's just what his skin looks like. But the daycare was like, we've seen thousands of kids. We've never seen this. This looks like bruising. They made a report. We brought him in for a medical exam, and I agreed. He had stuff on his body that looked like bruising, but as we were able to go through our medical evaluation, he ended up having a dermatologic or a skin condition, a medical diagnosis, and they weren't actually bruises. They were just what his skin looked like. And so getting the right evaluation and the right information back to DCF then, again, they could make the right decisions for this family to make sure that this kid and family received the correct response. The last thing that I just want to mention is the payment piece of this. Medical providers across the state are currently seeing these children sometimes. When they see them, sort of, and this is not just in Kansas, but across the board, pediatricians and family medicine doctors and emergency room doctors consistently say that they don't receive enough training during their residencies or fellowship programs to feel comfortable doing these evaluations. But they're doing them because they're the only person there to do them. These evaluations are really time consuming. When kids come to our clinic for these, they're getting the most in-depth medical evaluation they've ever had. It takes several hours. When we submit for reimbursement from insurance or Medicaid, we get reimbursed at the same rate as like a general physical exam, which is a 15-minute appointment. And so they're not being reimbursed for their time, and especially those in private practice, this can be a significant burden on them when we're asking them to see a child for an evaluation that will take 2 hours, but we're only going to pay them for 15 minutes of their time. And so part of the funding here reimburses at a fair rate for their time and the expertise that they have to do the correct exams. I also will be happy to answer any questions when we get to that point. Thank you so much.
Dr. Hanson, thank you for your testimony. Committee, our final oral proponent is Kelly Mark, Director of Family Health. Kelly, welcome to the committee, and if you wouldn't mind restating your name for those listening online.
Sure. Good morning, Chair Hildebrand and members of the committee. My name is Kelly Mark. I'm the Director of the Bureau of Family Health at KDHE. Thank you for allowing me to present proponent testimony for Senate Bill 460. This bill calls for the development of a program within KDHE to provide training and certification for care providers, as well as provide reimbursement to train care providers for performing care exams. KDHE is in support of this bill and commends our partners in establishing this promising practice to address and investigate child abuse. KDHE stands at the ready to develop and implement this program. I would like to reiterate what the other proponents have said. Adequate funding needs to be in place for this program to be implemented, developed, for KDHE to train and certify the care providers, and for the reimbursement of the care exams. KDHE has sent in a fiscal note. I'm sure you all have it. The cost is around $819,000 for fiscal year 23. Thank you very much, and I will stand for questions at the appropriate time.
Kelly, thank you for your testimony. Committee, I would direct your attention. We do have 3 written-only proponent testimony. Deanne Dinkle with DCF, Melissa Johnson, Senior Assistant for the AG, and Rachel Marsh, CEO, Children's Alliance of Kansas. Was there anybody else that wanted to submit written or proponent testimony? Okay, not seeing any committee, we will open up for questions for the conferees. Senator O'Shea.
Thank you, Mr. Chair. First off, thank you to Senator Baumgartner and everyone that's worked so hard on this issue. I'm really pleased that we're making strides for this. My question's for Dr. Hansen. You were sharing about, you shared the examples, which I really appreciate examples, so thank you. But the family where the baby had this skin condition and they thought it was bruising and it was just really a skin condition. What was the process like for the parents? I mean, how were they told, hey, we're gonna do this large evaluation and we have to contact DCF? And then how did that all play out?
Sure. So we received the referral through this program from DCF. So by the time the family came for their medical evaluation, DCF had already been called. My understanding, although it is confidential, is that the daycare made this report based on what they saw in the child. So I don't know what the conversation looked like when the family was told DCF would be called. When we rolled out this pilot program with DCF, Dr. Killo and myself worked a lot with DCF leadership and the investigators locally in those counties to sort of help figure that piece out, because that was a question. Like, how will DCF come back to these families and say, hey, we submitted this information and now we think you need to go have a medical exam. And so the way that we do this, because this comes up for us in the hospital too, families bring in their kids for some concern, and then a medical provider somewhere looks at their body and then has a concern that they want further addressed. So what we talked about is that my role as a child abuse pediatrician is not only to identify when something is abuse, but when to identify something is not abuse. And when we look in our clinic collectively, we sort of split about 50-50. So in terms of making a diagnosis of abuse versus not abuse. And so I think that's significant because somebody has to refer a child to us. So somebody in the world already thinks a child is abused, and then they come to us, and about half the time we do our evaluation and say, actually, no, this isn't abuse. It's a skin condition or a bleeding disorder or whatever it is. And about half the time we say, okay, yes, we do have concerns for abuse. So whenever we have these conversations with families, that's sort of how we suggested it be presented, that their child has something that is unusual. I don't know if it's an injury for sure. I don't know if it's abuse for sure, but there's something that's unusual and we need to figure out what it is, both for his current health. Is this a medical condition that we just need to know about to make sure that moving forward he's healthy? Or is there an actual safety concern for him? I think the other piece of it is remembering that children have contact with more people than just their parents. And so there are other people in the world that come into contact with their children who could potentially hurt them. And so we've sort of, when we had conversations with DCF, that's sort of how we phrase it, and that's how we suggested they do it. It's a recommendation. We had experts look at it, they had some concerns and think we need to do some more medical evaluation. So far, I have not been made aware from DCF that any of their families had issues with this request. Again, we have a small-ish number and a short-ish time. On the flip side, we do this in Missouri, and the program in Missouri with this referral system has been in place since 2016. And so just over 5 years, and it's also the exception there. So when Children's Division, which is DCF in Missouri, goes back to a family and says, we think that there needs to be some additional medical evaluation, this is where we think it needs to happen or why, families almost always are very compliant with that and also want to make sure that their child is healthy. Sorry, that was a really long answer.
Senator Petty.
Thank you. Doctor, you can just stay there. But this wouldn't change in any way mandatory reporters because, as you mentioned, in the situation that you referred to, the daycare, they're mandatory reporters. They don't have an obligation to tell the family. They have an obligation to report. And then the report, then the agency, DCF, or law enforcement, they go back to the family. So we're not, I wanted to make sure we're clear here. We're not interfering that process at all.
Absolutely, you're exactly correct. The existing sort of procedures for mandatory reporting and even DCF's internal procedures for doing their investigation, all of that will stay the same, except that there is an additional requirement for DCF to make this email referral for those children under 5.
Thank you. I do have a question for Kelly Mark. Thanks, Kelly, for being here. So in this bill, it's talking about 3 positions, and I'm going to assume those 3 positions are for training.
Yes, well, we would need a reimbursement coordinator to track all the exams coming in, make sure those providers were reimbursed appropriately, somebody to track the data around how many exams we were reimbursing for, and the fiscal piece of that. We would also need a position in our fiscal department to actually make those physical payments. There's a whole system within KDHE for ensuring that checks go out the door for reimbursement. And then there's the training and certification piece that would also have to happen.
So are those 3 positions for training at all?
Yes, one would be for the training and certification.
So as a follow-up to that, Dr. Hansen is in the Kansas City metropolitan area, and so I'm going to, and since there's a pilot there, I'm going to make an assumption that there's some physicians that are trained currently, but then talking about across the state. So then are you looking at this as being like part of an annual training for docs that it can
We
go
would
on
more
or
than
biannual?
likely contract the actual training of the physicians to our experts, and we would need somebody within KDHE to facilitate those trainings, make sure we had the location set up for them, track the evaluation of those trainings, but the actual physical training of the physicians would most likely be contracted out to our experts.
And then it was mentioned about the 819,000, that's not from SGF, that's not for those 3 positions, those 3 positions to be outside of that. The 819,000 is for reimbursement?
The 819,000 includes all personnel costs as well as reimbursement.
And lastly, there was a mention about adequate reimbursement. And I don't know that I saw that referred to in the bill.
The Missouri program that's been talked about today, their reimbursement for these exams is a maximum reimbursement of $750 per exam, and that is the figure we use for our fiscal note.
And is that covered in that way? I mean, in some way in the bill? I guess I should ask Jenna.
I do not believe that language is in the bill.
Okay, thank you.
Thank you.
Senator Gossage.
Thank you, Mr. Chair. I guess I would have, could you come back up? You're just here, I apologize. Or maybe one of the doctors could answer, but if you can help me with this, it sounds like you had some of the answers to my questions already, so I'll make this quick. Of the 819,000, to piggyback off of Senator Petty's question, so this is for training, and you said that would be contracted out. So that's included in that amount.
Yes, it is.
And so it was also brought up, insurance is not reimbursing this. So if a child is brought or is referred or brought in, does Medicaid reimburse this currently?
The Medicaid reimbursement, as the doctor mentioned, is only for a 15-minute exam, so it's very low. These forensic exams can take up to 2 hours. So if we were to go with Medicaid reimbursement, that wouldn't be appropriate reimbursement for the physician's time in performing these exams, which would make us fear that they wouldn't want to get trained and perform these exams if they're not going to be able to be appropriately reimbursed.
So then when it comes to Medicaid, is that something that we can do through legislation here, or is that something that would have to come from the federal government? Does Missouri have this currently? 3 questions.
I would ask if the doctor knows the answer to that question.
The way that we set it up in Missouri, so I don't know the answer about who can legislate what Medicaid would pay, but in Missouri, through the building of this program there, we ultimately decided that it was not feasible because of the reimbursement structure through Medicaid to get providers reimbursed at a reasonable rate. So what we did, though, was build into the rules for reimbursement that a provider could not bill Medicaid or insurance and receive payment from the state. So they can't double dip. It's one or the other. And for you to get payment from the state, that $750 reimbursement, you had to be up to date on your care provider requirements. So you had to be maintaining your continuing medical education and training to be able to draw that better reimbursement. So we tied that reimbursement to the training so that the expertise would stay at the higher level.
So the state would be picking up the full cost of the bill for a child that's on Medicaid?
So yes and no. It would be the full cost of the care provider's time. Things like x-rays or laboratory tests or additional testing would still be billed to Medicaid or a child's insurance.
So then the provider would bill for the 15-minute exam?
They would not.
They
They would
would
not bill for their time for the exam. They would only bill the state for their exam, and then they would bill insurance or Medicaid for lab tests or x-rays.
It seems like we could do the balance, doesn't it? Because if Medicaid is paid for partially by federal dollars, and that portion was reimbursed to the provider, the balance could be paid by the state for this. Just asking. Okay, and one, real quick, Mr. Chair, if I may, how many referrals have we had in the last 12 months in Kansas, and how many in Missouri? Do we know?
So DCF, abuses of child abuse to DCF in the last year were 39,760, somewhere around there. Yeah, we don't do care exams here, so we didn't have a number for Kansas for actually how many care exams would be needed. So we based that number on the population of Missouri versus the population of Kansas and the number of care exams that were reimbursed for Missouri. So we're anticipating around 600 care exams for fiscal year 23.
And that was then factored into the calculation?
Yes.
And Senator Gossage, maybe to answer your question about Medicaid, our Medicaid director would have to file with the CMS, and then we always have that pesky little thing called budget neutrality with Medicaid rates, so that would be a pretty large obstacle to overcome. Any further questions? Senator Steffen.
Thank you, and this is for whoever wants to answer it. What evidence do we have that this training and expense equates to better outcomes would be my first question.
So in Missouri, and I'm speaking about Missouri just because that's where I have the most experience because our program is involved with their program. Like I said, it went into effect in 2013. We anecdotally can provide you every year several dozen cases where this was a catch of a child that was missed on one side or the other, either incorrectly diagnosed as abused or incorrectly missed as an abuse case. But there's also a large amount of published literature in the medical peer-reviewed journals that talks about misdiagnoses of abuse and on both sides, whether we're making it incorrectly or we're missing a diagnosis, and changing outcomes for children based on better provider recognition of early injuries and more minor abusive injuries, and better outcomes for families in terms of targeted prevention services. And so there is published literature to support this. There is not a national sort of training standard for this sort of program. There are a handful of states in the country that are doing something like this, so we really kind of are paving this road here. We're sort of ahead of the majority of the country in this place. And so there's not like a curriculum that exists that we can use for this. And so this is something that has been developed in Missouri by the child abuse pediatricians in St. Louis, in Columbia, Springfield, and in Kansas City, and rolled out for the state. And so we have sort of a baseline curriculum, and then we also ask our care providers in the state, what is something that you want to learn more about? What's an area that you feel like you need more training? And so we do some targeted training in that way as well. We built the curriculum around sort of the basic training standards for a child abuse pediatrics fellowship. Obviously, that is a 3-year fellowship program. There is no way we can train people to do that in a matter of days, but we took some of the biggest features from that to build our curriculum.
Okay, so yeah, you've done the 3-year fellowship?
Yes, sir.
Okay, and to distill that into how many hours of additional training are they doing in Missouri?
So they're doing 16 hours initially and another 6 annually. They also have in Missouri some required mentorship so that their first 20 or so cases have mandatory sort of mentorship with their mentor. And then after that, it's sort of on an as-needed basis. So this sort of graduated.
Oh, and do you see are these doctors getting paid to do the training, or is this CME? It sounds like CME to me.
It's CME.
So they should be paying for it.
So in Missouri, we have made the CME free to them. They have to pay to get to the training, right? But we've made the CME free because we want providers in local areas to come to this. We want to sort of make it very accessible to people because right now, doctors are doing it in rural Kansas. It's just that they're not doing it well because they don't have the training. And so we want these doctors to have the right training. So we wanted to make this as easy as possible for them to access it.
How do you know they're not doing it well?
Well, because they eventually come to me and we see them in some cases.
They?
The children.
Thank you. Okay, just real quickly, I am very troubled by the idea that a huge department like Health and Environment can't absorb a great deal of this and needs 3 FTEs. That sounds really out of control. And the $750 per exam, I don't see those taking 2 hours, particularly for a person who's had 60 hours of training in it. I think that will turn out to be an incredible windfall for a pediatrician. And I think that somehow has to be changed to a time-based sliding scale. But even then, that sounds very exorbitant. But I appreciate it. Thank you.
One last question from Senator Thompson.
Thank you, Mr. Chair, and this would be also for Dr. Hansen. How many in Missouri, how many providers are trained like you are, and how many, since in the last 5-year period, have joined on or taken this kind of training? Just kind of curious.
Sure. So there are child abuse pediatricians in Missouri. There are 12, I believe. So that's me that have the fellowship training. And then the care providers, there are about 50 at any given time. And so some of them stop doing it for whatever reason. They change jobs or they retire. And then we get a couple of new ones every year. But sort of on an annual basis, we have in the ballpark of 50 to 60 care providers across the state who have done the training and are maintaining their continuing education requirements.
But generally, the people like you who have the full training oversee the other ones?
That is correct, yes.
Okay. All righty. Thank you, Mr. Chair.
Committee, that does wrap up our proponent testimony. We do not have any opponents listed. Was there anybody wanting to speak or provide written only testimony as an opponent? Okay, not seeing any. We also did not have any neutral testimony. Was there anybody wanting to provide written or oral testimony as a neutral conferee? Okay, not seeing any. Committee, we will close the hearing on Senate Bill 460. That does conclude our work today. Is there anything else that we need to discuss before adjourning? Not seeing any. We are adjourned. Thank you, everybody. We'll see you tomorrow.